So the next new protocol we're going to go over is the cardiac arrest after trauma protocol. I don't think we technically had one of these in the last protocol. It was just kind of, working it very similar to medical or cardiac arrest, except you considered needle decompression. So now we've got a protocol specific for traumatic cardiac arrest. So let's go over it real quick. So indications for this protocol include a unresponsive patient without normal breathing and without a palpable pulse, and the reason for cardiac arrest is believed to be a traumatic injury. If the patient is unresponsive, apneic, non-reactive pupils, and no palpable pulse, and there's a sign of obvious death, i.e., lividity, venous pooling, rigor mortis, or injury incompatible with life, so burn beyond recognition, decapitation, hemicorpectomy, something like that, then do not attempt resuscitation. If the arrest is due to penetrating trauma with the incident witnessed by EMS, immediately transport to a trauma center. Pregnant females at 24 weeks gestation or more, or uterine fundus palpable at or above the umbilicus, immediate transport to the nearest emergency department. So the next part is perform all these interventions en route and do not delay transport for CPR procedures, etc. The mechanism of injury appears inconsistent with cardiac arrest, i.e., a ground level fall with minimal external trauma, minor MVC, then consider a medical cause of arrest and treat under that standard cardiac arrest protocol. So, next part is if there is any pulse palpable at any point, then you need to immediately transport to the nearest trauma center. Also consider requesting air transport early. A lot of times when we get paged to stuff like this, either the fire department on scene will tell us that we have an unresponsive patient, or when we get dispatched, they might say there's an unresponsive patient or unconscious. I would just have dispatch go ahead and check flight status and have them put on standby. Initiate chest compressions if personnel are available, but you can defer until the next listed interventions are performed. Also defer spinal immobilization if you can maintain C-spine in a neutral position manually if possible, but you don't have to do it right away if you don't have the hands. So these are going to be our initial steps to treating a traumatic cardiac arrest here. You can defer chest compressions until after you do all these if you don't have the hands, or you can have somebody do chest compressions. So the first thing you want to do is control any external hemorrhage. So that's applying the tactical tourniquets, direct pressure, or hemostatic gauze if your agency carries it. So making sure you're putting your tourniquets on nice and tight, direct pressure, and hemostatic gauze, and then apply a pelvic binder if blunt trauma. The reason you apply the pelvic binder is just because your pelvis holds blood. So you want to close that pelvis up so it can only hold so much. You're not going to really stop the bleed so much, but your pelvis can only hold so much blood. So then you move on to volume replacement. So obtain an IV or IO. This protocol says a humeral IO is preferred, and if you have to do an IO, that is, access and initiate bolus normal saline or LR. Your quickest route is probably going to be to do an IO and then try to get a IV after that. After you get done with that, we're going to move on to treating obstructive shock. So this is where Dr. Blair's training on the finger thoracostomy comes in handy. So now we'll have the option to do bilateral finger thoracostomy or the needle thoracostomy, which is needle decompression. So if the mechanism of injury is anything other than an isolated extremity or head injury, you're going to decompress both sides of the chest. If you're doing a needle thoracostomy, then you want to use a 10 to 14 gauge, at least 3.25 inch angiocath. You can either do that in the fourth intercostal space at the anterior axillary line or the second intercostal space mid-clavicular line. I'm more of a fourth intercostal anterior axillary placement kind of person. That's just my preference, though. Either one's fine. And then after that, you want to treat any airway compromise. So BVM with an OPA is good if you get good chest rise and fall and a good end-tidal CO2 waveform. You may have to move on to advanced airway if basic maneuvers are insufficient or unpractical. So you may have to place a tube, you may have to put in a King airway or an iGel. But in any case, end-tidal CO2 monitoring is required. So you and your partner can kind of do as much of this as simultaneously as possible. Paramedics, if you've got your EMT partner, the way I would go about this is if it were me as the medic on the truck, I would go ahead and start an IO and start fluids while my partner was controlling any external hemorrhage with tourniquet, straight pressure, applying the pelvic binder. And then after that, I would move on to decompressing the chest while I let my partner do some basic airway management with a OPA and a BVM. And if I felt like it was necessary, either drop a tube or have my partner put in an iGel. After you do all of these interventions, check a carotid pulse and apply the cardiac monitor. Once you apply the cardiac monitor, paramedics do a rhythm analysis after the interventions are complete. If it's a organized rhythm, less than 40 beats per minute, or asystole, withhold further resuscitation and contact medical control for termination of resuscitation authorization. And as long as they say it's okay to terminate, contact the coroner, remain on scene until the coroner or law enforcement takes control, and do not transport the patient. If it's a organized rhythm greater than 40 beats per minute, consider repeat decompression of the chest. Ensure all hemorrhage is controlled. Consider repeat IV fluid bolus, and ensure bilateral chest rise and fall with the end-tidal CO2 waveform. If they are in VFib, VTAC, obviously you're going to defibrillate, and then you're going to do the same interventions as you do for the organized rhythm greater than 40. So repeat chest decompression, ensure hemorrhage control, consider repeat IV fluid bolus, ensure bilateral chest rise and fall, and end-tidal CO2 waveform. In these two cases, you're going to immediately transport to a trauma center. If they have an isolated head or neck injury, IV cervical spine injury from a hanging or whatever, you can consider 1 milligram epi IV, and you may repeat that in 5 minutes. So, I want to note that I don't think I put it in the PowerPoint, but there is a little excerpt in the protocols about ACLS drugs in traumatic cardiac arrest, and they don't really have a place because cardiac is not your cause of arrest. Really, it's some kind of shock, right? You're either hypovolemic shock or obstructive shock or something of that nature. So giving epi is not really what the patient needs. You can do that, like we just said, if they have like a head injury or a spinal injury, just for the neurology aspect of it. But other than that, there's not really a whole lot of place for ACLS drugs in a traumatic arrest. So let's move on to if we get ROSC after traumatic arrest. Our first priority is going to be neuroprotective care. So you want to make sure they have a good neuro outcome. That's the goal, right? We're not just trying to save lives, we're trying to save lifestyles. So to maintain their lifestyle, they have to have a good neuro outcome, right? So give IV fluids to maintain a systolic greater than 90 unless the patient is fully awake, alert, and has a GCS of 15. And ventilate them at a rate of 10 to 12 breaths per minute with a goal end-tidal between 30 and 35. If you're using a automatic vent, your initial vent settings are going to be a respiratory rate of 14, tidal volume 6 milliliters per kilogram, ideal body weight 100% FiO2 initially. You can titrate that to maintain SpO2 between 94 and 98. Next is going to be pain control and sedation. If a patient begins to move, display signs of consciousness, then administer fentanyl 25 micrograms IV push or 2 milligrams or 2 milligrams of Versed IV every 5 to 7 minutes until the patient appears comfortable. If the systolic blood pressure drops, administer IV fluids as above to maintain systolic greater than 90, and do not allow an intubated, severely injured patient to sit in pain. So this is already going to be a traumatic experience for them. There's no point in making it worse by leaving them uncomfortable and in pain. Every intubated patient should get sedation and pain management. And then you're going to continue to maintain hemorrhage control. Check your tourniquets and dressings. Be cautious of unrecognized wounds on the back or scalp. So make sure if you get ROSC and, even before you get ROSC, you check the back and scalp and make sure you don't have any injuries back there that may be bleeding. If the patient is unconscious and in shock or complained of hip or pelvic pain when conscious, apply a pelvic stabilizer. You should have already done that. You should have put the pelvic binder on as your treatment for hemorrhage control, and then splint or redress injured extremities. I want to go back to that check tourniquets and dressings thing real quick. A run I went on recently, we had a patient who got stabbed in the leg and he nicked his femoral artery. We put the tourniquet on and bleeding was controlled at that point. He went to cardiac arrest, and we ended up meeting PHI because he arrested as the helicopter was landing. So we let them come with us and they gave a unit of blood. So when we got ROSC, he started bleeding from the tourniquet again. So I think it's always good, a good thing to continuously reassess those tourniquets, because his blood pressure was probably so low right before he arrested that the tourniquet was controlling the bleeding. But once he got ROSC and his blood pressure was a little bit higher, then the tourniquet wasn't on tight enough. So just make sure you're continuously checking your tourniquets, make sure nothing's bleeding, and then one of your top priorities is going to prevent hypothermia, and you should consider actively warming the patient. So I know it's really hot outside, especially during the summer, but you've got to turn the air off in the back of these trucks during these kinds of situations, because hypothermia leads to worse outcomes, especially in trauma patients. So just keep that in mind. I know it's not comfortable. I'm a big guy too, so I know, but you can't let these patients become hypothermic.